Good evening, everyone. A very warm welcome to all of you. And thank you again for joining us today. On behalf of Heartlines West Bengal IACTA, it is our privilege to welcome all of you to our episode 2 of the ECMO Essentials mini series. The series is designed to move beyond the protocols and machines and to explore the known as decision makings that defines the real world ECMO practice. So, after an insightful first episode, today we move into one of our most challenging and intellectually demanding aspects of ECMO core, that is, the walking the fine line, the hemodynamic challenges and monitoring in ECMO. The hemodynamic instability on ECMO is where the physiology, technology, and clinical judgment intersect. And mastering this balance is critical for the patient outcomes. So we are truly honored to have with us Dr. Arpan Chakraborty, who needs, I think, no introduction. Sir brings the vast clinical experience and a deep understanding of physiology and is very well known for translating complete complex concepts into a very practical passion for teaching have inspired many of us across the all disciplines. So this session promises to be a highly relevant for all anesthesiologists, intensivists, and the perfusionists and all members of ECMO team who are involved in our day-to-day management and the troubleshooting. So we encourage the active participation and discussion during this session, as learning in ECMO is best achieved through shared experience and thoughtful thinkings. So once again, thank you all for being with us here in this evening. So without further delay, it is my pleasure to invite Dr. Arpan sir to take us through today's session. Thank you, and over to you, sir.
So thank you. This is the second lecture of the series, which I'm going to mainly discuss on how to continue ECMO. So it will cover the monitoring, hemodynamics, and what we do regularly basis. I have decided to put a case and just go through the case, how we manage this cases in our day-to-day regular practice of ECMO. So be with us for the case. Now, I have used some photos which are taken with the permission of the patients and the people around. So let's start with a case. This is a case which was there in 2018. And it was a 32-year-old female, full-term pregnancy. She became febrile just 2 days before Eleusis, and Eleusis done after that. Now the fever recurred after two days of Eleusis. She became mildly dyspneic. Saturation somehow maintained around 96% on BiPAP and found to be the swine flu positive, H1N1 positive. Now, what we are going to discuss is a post-cesarean section, as a peripartum viral ARDS. Now, this was the X-ray with initiation. You can see some changes are happening in the lower zones. And because of the progressive hypoxia, she has been transferred to a higher facility with an increasing respiratory distress. There she got intubated and ventilated, where 80% of FiO2 was the requirement, with a barely maintaining a saturation of 92%. She is hemodynamically stable. PEEP was applied 14 over there. ABG showed a PO2 of 66 with a 80% of FiO2 and PCO2 of 54. So if you calculate, the PF ratio is basically less than 1. Now, a postpartum thing and X-ray, comparing with the previous one, it has become white. Almost all the corners of the X-ray looks white, and it's ARDS. Now, the question is, what is the ventilation strategy we adopt in case of ARDS? And what are the ventilatory adjustments we did? Like sedate and paralyze, probably the follow the ARDS net protocol. And then we wanted to do proning. Now, she has been a recent LUCS, and because of the recent operation for last 2 days, the proning was a bit hesitant in that hospital. Now, what we did, the question is whether should be proning done in such patients. Whether after that we did a lot of proning in this kind of patients, but in this patient, it was in other hospital, they were not very much keen to do proning because of the suture line. Just LUCS done 2 days back. The uterus is not yet involuted, and a lot of issues. So now coming with the patient again, the patient started getting deteriorated, and saturation came down to 85 with a PF. Your FiO2 requirement went up to 1, and the proning has not been considered over there. So we have been called, the ECMO team has been called over there to manage this patient. Now, what is your next? So without proning, now this is a PF ratio of less than 1 and severe ARDS post LUCS status. Automatically the question comes with whether we can do ECMO or not. So if you followed the previous lecture, I have discussed about the different indications of ECMO. So this is found a classical indication of ECMO where ABG shows a pH of 7.22, PO2 of 47, with a PF ratio of 0.47, PCO2 has risen to 56, and a peak pressure of 42 is noted. So PF with a PEEP of 16. So lung is tight. And now whether ECMO is indicated, so probably it is yes. And so referral for ECMO done. And what is the indication for ECMO? As I have told you, lung disease that is acute, life-threatening, reversible. So all these points are important and unresponsive to conventional therapy. So why ECMO is indicated? Because it's an acute life-threatening disease. H1N1 ARDS in a young female with post-LUCS, potentially reversible and unresponsive to conventional therapy. So these are the indications of VV ECMO in these patients. Now, coming to the Caesar trial, this has been discussed in the previous one also, that what we have seen that there are two arms, where the ECMO arm and the conventional ventilatory support arm. So there is a clear-cut mortality benefit in the ECMO arm. And what they have calculated before putting the patient on ECMO is the Murray score. Now, Murray score is a conglomeration of 4 points. One is the PF ratio, chest X-ray, how much PEEP you are giving, and the compliance. So with these 4 points, if you are calculating a Murray score, and if it is coming more than 3, you should start speaking of ECMO. And if it is more than 3.5, you should start putting the patient on ECMO. So any patient who is getting referred to you for an ARDS, for an ECMO, you should calculate the Murray score. If it is more than 3, so start discussing about the ECMO. If it is more than 3.5, so it is coming. It's an absolute indication for ECMO. Now, as we know, ECMO, whenever these kind of patients are falling into that trap of severe ARDS and nothing is working, like this patient, where we consider as a VV ECMO is a rescue strategy. And this is when a previous discussion also we have told that the reversibility of the organ recovery should be there. So prior to initiation, you should always think the likelihood of organ recovery. And you should deduct these things like multi-organ dysfunction should not be there, like our patient doesn't have much. Disseminated malignancy is again a related contraindication. Advanced age, known brain injury, unwitnessed cardiac arrest, or prolonged duration of technical issues. So here the main issue is that it's a reversible, potentially acute life-threatening event which is happening, and the ECMO is going to help here. Now, how the ECMO is useful in this particular case? So if we put the patient on ECMO, what are you going to achieve is just maintain the tissue oxygenation, and it allows the lung rest. So if anybody asks me that why are you putting the patient on ECMO, these two are the answers. Just to have tissue oxygenation and the lung rest. So where the ECMO actually indicated in this patient. Now, if you see what we do on ECMO, again, we just drain blood from the major vein through a pump, and it goes again to a membrane of gaseous exchange through a oxygenator, and then return to a large vein or artery. So this is the circuit of an ECMO. And these are the three we follow. Like the previous discussion was on decision for ECMO, the physiology and different things that this patient needed ECMO. Then we need to cannulate that patient. Then we need to initiate ECMO. Then have a maintenance and this weaning. So how to cannulate and where to is again to be discussed. As I have told previously also that we put two cannulas here. One is the drainage cannula, one is the return cannula. Return cannula here is called as the arterial cannulas. As I have told you, these are usually these return cannulas are put in the right-sided jugular vein as an appropriate size. So these are the sizes which I put through the right internal jugular vein for this patient for VV ECMO. And for the venous cannula, for the drainage cannula, these are the large cannulas with the multiple holes are the cannulas for your drainage. It goes from the right or left femoral vein up to the intrahepatic part of the IVC to drain the as much as blood from the venous system. Because if you remember, your centrifugal pump which you are using is dependent on the preload. So if you give as much as blood from the IVC, the pump will work better and you can give as much as good flow through your ECMO circuit. So this is the way you can get a maximum oxygenation. So venous cannula, which is again the drainage cannula, which is a bigger one, which goes till intrahepatic IVC, and this is a return cannula which goes through the internal jugular vein up to your SVC-RA junction for the return of this femorojugular venovenous cannulation. Now this is the some picture which you can see a return cannula has been placed in the neck through the internal jugular vein. This is the way we do it. And this is your femoral venous cannula, which is placed in the groin. These are the serial dilators which you have used, starting from the basic triple lumen dilator to the largest dilator of the venous cannula. So this has been placed in the groin. So this is your femoral venous drainage cannula, and this is your femoral venous, your jugular venous return cannula. So this is the way we do the femorojugular venovenous ECMO for this patient. Now, how it actually looks like, if you see, this is the patient. This is the drainage from the groin, from the intrahepatic IVC, coming down, and it is going into the ECMO machine, and the red blood is again coming through that and going to the neck of this patient through the return cannula, and usually they look like that. This is another picture of the another patient. So this is the thing actually happens. What happens to venovenous cannulas? And this is the same patient where the lady where we put the your jugular cannula for the return. And this is the groin cannula. Now, this is a picture after putting the cannulas, how we are going to see your cannulas are in actual position. So there are some real-time things and there are some imaging you can do afterwards. So as a cardiac anesthesiologist, it is always easier to do a transesophageal echocardiography because it is available along with us always, but not for all critical care setup where transesophageal echocardiography is not that easily available. So if you have a transesophageal echocardiography, you should put a transesophageal echocardiograph probe here and just check two cannulas position. The drainage cannula should be at the level of the SVC or IVC RA junction, just around your drainage of the hepatic veins. You can see jolly well in the bicaval view. And the return cannula should be at the level of SVC RA junction, just above it. So you can see again both the cannulas. The cannula should not come very closer to prevent the phenomenon of recirculation. And what else you can see from echo at that point of time, you can assess how is the LV function, how is the RV function, and how is the overall cardiac contractility, overall preload. So you can do a good echocardiography at the bedside during cannulation. So this is the picture which depicts that we are doing transesophageal echocardiography during the cannulation. Now you can do, if the transesophageal echocardiography is not available, you can do things with your transthoracic probe also. In the IVC view, you can see the position of the cannula at the level of IVC-RA junction, just beneath the IVC-RA junction. And you can see the position over there. And you can see the heart to the normal transthoracic views. So both can be done over there. Next coming here, the position of the cannulas can be ascertained by your X-ray. X-ray can shows the cannulas are at the level of your xiphisternum or cannula at the level of second intercostal space. So these are the things where you can see, you can be assured of your cannula position and a definite distance from two cannulas to prevent the recirculation. Now, this is the picture of the transthoracic view, transthoracic echocardiography, where the IVC, you can see the cannula over here, the IVC view, which we do daily basis just to see the volume thing when the patient comes in the ICU, the general ICU. I'm talking about the general ICU where transesophageal echocardiography is not that easily available. So you can see the cannula in the IVC. Now, after the cannulation, next comes to the how to initiate the ECMO. So once the cannulation is over, you have given the initial dose of heparin of 1 mg per kg to facilitate the cannulation. So then you put allow the clamp to open up and run the ECMO as your need. So this is the thing where you can see this ECMO is running over there, and this is your pump and this is your oxygenator. You can easily identify this is a quadruple oxygenator, which is very much common in use, and the blood is going from here to the pump and then coming to the oxygenator, and the red blood is going out of this oxygenator. So you allow the flow to happen as much as your requirement. It should be at least 70% of the patient's cardiac output flow you should return to the patient. So if the patient's cardiac output is measured around 4 liter, I have used this patient around 3 liter of flow with around 2500 of RPM, so that we can give a 3 liter of flow, so that this 3 liter of flow goes through your membrane oxygenator for the oxygenation and give a good oxygenated blood into the RA, which actually ultimately will be delivered to the left side of the heart. So this is our motto, to give a at least 60 to 70% of your cardiac output through your membrane lung, bypassing the diseased native lung. And third one is the temperature. You know, as long as the blood will come out of your uh, body, it is going to cool. So you have to give your temperature at some point of time to maintain the around your whatever you need. So in case of VV ECMO, what we practice is a mild hypothermia. So we just kept our temperature around 35, so that the oxygen demand comes down by decreasing your uh, cardiac output around a normal or a little bit subnormal level, so that the native blood flow, the native cardiac output is to ECMO blood flow, the ratio is usually maintained around 70%. So the temperature is maintained around 35. And look at the setting of your blender. Now, this is most important. This blender, as initially I have told you, the blender has two components. One is your flow, how much flow you are giving. This is for the liters. And another is your FDO2, fraction of delivered oxygen, how much oxygen you are giving. So this is FDO2, this is 1 to 0.21, 21%, and this is your flow. So this indicates that how much FDO2 is going, and this is known as sweep gas flow. And the color change should be remarkable. This is the color of your drainage cannula, and this is the color of your return cannula. Marked difference. Black and red, blue and red. There should be marked difference. When this difference will go, something is in problem. Whether it is recirculation or the oxygen delivery is not adequate. If the both cannulas are red, it is known as the recirculation. If the both cannulas are the same black colors, oxygen is not getting delivered to your oxygenator. Some oxygenator failure is happening. Now, coming to the ECMO physiology, as I've told you, the oxygenation is mainly dependent on your pump flow, how much flow you are giving, and the FDO2 you are supplying to the oxygenator, and your carbon dioxide removal is related with how much sweep gas flow you are actually giving. Now, after putting the patient on ECMO, the saturation went up from 85 to 100, and we decreased the FiO2 of the patient because just to have a lung rest. Now, the important part of maintenance of ECMO or the maintenance of continuation of ECMO is the anticoagulation. What is the anticoagulation strategy of when you run an ECMO? Now, what happened when you do cannulate? We usually do an heparin of 1 mg per kg. Like a 50 kg, 60 kg, we give 50 mg of heparin and do cannulate. And we measure an ACT after an hour, and we start heparin infusion after that. This is an also has told us to just start heparin at 12 units per kg per hour if your post-cannulation ACT is less than 200, and then measure the ACT 2 hourly for first 24 hours. Your target ACT should be 150 to 180. If your platelet is less than 80,000, heparin can be discontinued. After 24 hours, you can shift to 24-hourly APTT as an anticoagulation measurement. So if you can follow this, it's well and fine. But some problems happen, some deviations happen where you do a lot of changes. But this is your basic thing, how you start giving heparin when the ACT is your target. And for first 24 hours, again, we all use the ACT as our target. So this is heparin as an anticoagulation strategy. Now, apart from this, we have a lot of managements during running of ECMO. So we can broadly classify this management into circuit related and a patient related. Now, what are the circuit related management? As I told you in the previous one, if you are whenever managing an ECMO patient, it's actually two things you are managing. One is the patient, one is the ECMO machine. So it's a circuit related management. Obviously, you have to have a checklist over there: the blood flow, the ECMO flow, oxygenation, FDO2 flow, and what is your saturation? How is the CO2 clearance? Anticoagulation as the form of ACT or APTT, whatever you are managing. Some circuit monitors, alarms, and safety, which are inbuilt, something you have to measure. Component and circuits, these are all fine or need any changes, and whether you have to travel or not. You have to shift the patient for CT scan or in a different healthcare setup or not. So these are the 7 points are mostly seen by the circuit related management. So what is our management over here? For the goals for the VV-ECMO, we have to maintain a saturation of more than 85% just to have a adequate oxygen delivery at the level of tissues. Hemoglobin should be more than 12. Now, there are a lot of controversies. Initially, we used to keep it more around 12, then we came down to 10. Now, for initial part, we just keep around 10. Later on, we try to keep it around 8 if there is no drastic fall. Now, PCO2 should be less than 50. As I have told you earlier also, if you have a very high PCO2, you should not come down drastically. This will increase your cerebral bleeding. Chances of PCO2 is less than 50 is fine. pH, 7.3, more than 7.3. MAP for more than 70. SCVO2, if you can measure, it should be more than 70. So this is your goal for VV-ECMO. Out of that, saturation more than 85 is the predominant target of your VV-ECMO. Now, blood flow. Blood flow, again, is the surrogate of your oxygenation in VV. In VA, if you remember my previous class, actually, if you put a peripheral cannula, if you increase your VA flow, it goes retrograde. So in VA, we just measure a flow of around 60% just to have an arterial pulse pressure of around more than 10, so that your aortic valve doesn't get closed. But in VV, the ECMO flow is beneficial. The more you flow in the ECMO, more will be the good oxygenation. So VV flow, blood flow should be optimized if your saturation should be more than 85. So at least a 70% of your present cardiac output flow should go through the membrane oxygenator, bypassing the diseased lung to have a saturation of more than 85. Now coming to the CO2 clearance, CO2 is predominantly dependent on the sweep gas flow rate. Initially, we set it up around a very minimal level. We try to start with 0.5 to 1 liter per minute. Then we go up every half an hour just to have a gradual CO2 drop. So you have to keep in mind, because this is a very important thing, because if you get a patient who has a CO2 of 130 and you have put the patient on ECMO, we are in a hurry to come down to 130 to 30, but this is very detrimental. The oxygenation can be improved at that point of time or in hurry, but we recommend not to reduce CO2 by at least 20 millimeter of mercury by each 15 or minutes to half an hour duration, because there is a direct correlation of CO2 clearance, the hurried CO2 clearance, with the intracerebral bleeding. Remember, the intracerebral bleeding is more common in VV-ECMO, as we have thought, than VA-ECMO. So be careful. There is a direct proven side effect of reducing carbon dioxide in ECMO with the intracerebral bleed. So there is a 11% clear-cut evidence of your VV-ECMO patient is going to bleed in the brain if you come down on the CO2 very fast. So make it as a habit, 0.5, 1 liter, slowly go up, and have around, if you are flowing 4 liters of flow, just have a 4 liter of your sweep, as the PCO2 should be around 45 to 50. Now, next is the hemolysis. This is a silent killer. We have found many a times that when we put the patient on uh, ECMO, sometimes we get your urine is turning into red and then it's turning into black. So what is happening? It is an hemolysis. It can be some amount of hematuria, but that is not that much detrimental, but it's hemolysis. Why it is hemolysis happening? Because your patient is dry and you are sucking too much. So you need to give some fluid or need to decrease your pump flow, need to decrease your centrifugal pump negative pressures. The P1 should come down so that lesser is the cell injury, the cell breaking. So you cannot give too much of suction in the intrahepatic IVC if it is dry. So you have to fill the patient first, then you come down on your flow, and then you see whether this hemolysis is happening or not. There are cases where there is slow hemolysis. We can get some clots in the pump head or in the oxygenator that can lead to slow hemolysis, where you can see that plasma free HB goes up slowly, or the patient is turning to be icteric slowly, or you have a slow renal bad perfusion or slow renal failure. So it's a silent killer sometimes if you are not very much careful about it. A lot of people ask me, what are the investigations you should be sent on regular basis? See, in ELSO website, a lot of things have been written, but people are practicing, but frankly speaking, that everything is not required every day. So this is your investigation you should send, but you should space it out. Like everyday CBC might not be required, urea creatinine, ACT and APT. As I've told you, initial days, the first 24 hours, the ACT will be better to measure. APTT probably after that for 6 hourly or 8 hourly can go. Chest X-ray and echo probably can be spaced out well 2 to 3 days. LFT and INR, if the patient is doing fine, no need of check it every 72 hours. Magnesium, potassium, sodium as you required it. A peripheral smear or plasma-free HB, it is required obviously just to have an idea whether hemolysis is happening or not. Pan cultures. We don't send pan cultures now, probably first pan culture. After that, if you suspect any kind of infection, there is a drop in blood pressure, or there is a rising total count, or the patient is turning to be not responding. If you are having septic encephalopathy, you can send pan cultures, and CRP procal also to be spaced. So all these investigations should not be sent every day or every interval. You can space them out to reduce the cost and to make your things bit clinical. A lot of things can be available on your ABG. So probably a twice daily ABG is as beneficial as your things, and every like potassium, sodium, this can be managed through ABGs. You don't need to send in the lab. So these are the basic investigation you should send. Now, after the circuit related things, you come to a patient related management. Now, whenever the patient is put on ECMO, you should come. What are the things you should observe? Obviously, the first one is the hemodynamics. What is the blood pressure? What is the pulse rate? What is the saturation? And all these things. Next, come to the ventilator. How you come down on the ventilator to a rest level. Sedation. Patient needs to be sedated. In the hyperinflammatory ARDS state, they're so tachypneic, breathless, and everything happens. Blood volume, fluid balance, and hematocrit. These are most important for the initial 48 hours. VV-ECMO needs fluid, VA-ECMO needs fluids in the first 48 hours. Temperature has to be controlled. As I've told you, we keep it around a mild hypothermia from 35 to 36. Renal and nutrition management. This comes little later on from the day 2 or day 3 where you are starting feeding, and infection and antibiotics. Here I want to tell you something that it's a there is a keynote or there is a gist if you run ECMO every day or on your regular practice, three things should be kept in mind. If you want to get your ECMO patient out of this mess or out of this disease to get a successful ECMO story, three minimal things you have to do. Number one, the cannulation should be as good as possible. There should not be any problem during the cannulation. It should be good. The flow should be good. So, good cannulation. Number second is a good anticoagulation. Patient should not bleed or patient should not clot. Your anticoagulation strategy should be as robust as possible. Third one is the prevention of infection. If you prevent the infection, if you prevent hospital-acquired infection, if you prevent any kind of infections, any patient in the earth is going to come out of ECMO. We have seen whatever maybe the problems can happen. These three are main contributor of your ECMO deaths. A good cannulation, a good anticoagulation, and a good infection control. Keep remembering these 3 points. These are the 3 very basic points where you can get a good outcome from your ECMO patients. Now, ventilation and sedation strategy on ECMO. All of us know this. We can come down on FiO2. The PEEP should be around 10 to 15. Peak inspiratory pressure should not go up more than 20 to 25. Rate is 8 to 10. Increase in inspiratory time just to prevent all these traumas. In here, I'm just telling you, the most important is don't allow the inspiratory pressure to go up more than 25. We have a very bad experience during COVID. Whenever we allowed that thing to happen, the lung got ruptured in the form of pneumothorax, in the form of pneumomediastrinum, or in the form of surgical emphysema. So don't allow the pressure to go up beyond 25. You may get a 15 ml of tidal volume, you may get a 20 ml of tidal volume with that. Be happy with that, but don't allow the lung to put undue stress on this. Go for a lung rest for a period of time where you are thinking your lung is rock solid or is as hard as brick. So don't put any shear stress on your lung. Just allow inspiratory pressure up to 25, not more than that, maybe up to 30. Don't allow that thing more than that. So personally, I use pressure control ventilation just to ensure no pressure should go at any point in time should go beyond 30. Now, this slide earlier also I have told you how to maintain the saturation on VV ECMO and what are the factors determining your saturation. You know how much VV is going through the membrane lung and what are the things can be your membrane oxygenator dynamics, blood flow, most important, your membrane FiO2, that is the FDO2, and inlet oxygen, how much it is. The best ratio can be with the effective extracorporeal blood flow, decreasing recirculation, and decreasing cardiac output. So calm down on your oxygen oxygen use or oxygen consumption. Increase your oxygen delivery. So this will increase the effective extracorporeal blood flow, decreasing the recirculation. The cannula should be a little bit distant to it, and decreasing the cardiac output to improve your ratio of native blood flow and the ECMO blood flow. So this is the way where you can maintain a good saturation in the patient. Recirculation, as I've told you how it happens, this should be the color change, but usually color change happens like this. So there should not be any recirculation. Inspection of the tubing. This will give you the earliest idea that both the tubings are red. So there is recirculation is happening. You should keep reducing your RPM and increase the distance from the cannulas. And you can see the video, this is the classical way of recirculation, how it is happening. In every motion, look at the cannulas are getting the same color. And this is the way the recirculation happens. So what is happening actually? The cannulas are very much nearer to them and the return cannula or the drainage cannula is sucking the oxygenated blood on its own. So it is getting recirculated in the right atrium.
Hello.
So come down on RPM and increase the cannula distance. You can see the both cannula color is different. Both cannula color is same. So this is your first point to be noted, just to have your recirculation as a diagnosis. And the patient is desaturating. And after correcting, see the cannula color has become different. This has become the blue and this has become the red. So if you are after correcting things. Now, as I've told you, what are the investigations we do just to have echo and transthoracic or T, whatever is available, X-ray, not every day, and check position of the cannula, particularly after turning, particularly after giving back care. You have to keep in mind that cannula might migrate. You can see the position of the cannula in the X-ray. This is your drainage cannula went up to the intrahepatic IVC. You can see this. And this is your return cannula, which is little bit inside, but it has got cup up to here. You can see the return cannula. So good distance is measured. This should be more than 10 centimeter. And if you can see this cannulation, the drainage cannula has gone up to here, well inside the RA, and the return cannula coming here, it has almost touched here. So it is just meeting with that. So the recirculation is bound to happen. You have to pull both cannulas. Probably this will come down a bit in the IVC and this will come up in the SVC to have a good circulation. So the recirculation is going to happen because both cannulas are nearly very much touching each other. As I've told you, you can see the somebody is doing the echo every day at the bedside, just to have a look on this. What are the cannula positions, how the heart is functioning, and other things, the preload. Now, lines monitoring, as I've told you, it can be a thrombus in the drainage cannula. The outflow impairment can happen. So you have to be very careful whether any palpable kick or shake in the drainage line is there or not. It is called chattering. So confirm the pre-pump chugging is there or not, fluid desaturation to prevent hypovolemia, decrease your pump speed, reduce the RPM, correct cannula position, or add a second cannula. So there is a flow chart from here. And how it looks like, as I told you, there is a chattering of your drainage cannula, which gives a lot of ideas what is happening. So probably giving volume first, then come down on the RPM, then positioning of the cannula, check it, and then go for a second cannula. The same patient we found after initial improvement having some kind of increase in the bronchovascular markings in the X-ray on ECMO. So what we did, probably some LV dysfunction we have noted in the X-ray. So some water logging is there. As I told you, if your ECMO patient is waterlogged, there is a danger of coming out. So don't let the patient waterlogged. Now, same patient, when are we considering tracheostomy? Because the patient will require a long time H1N1 ARDS, and how? So probably tracheostomy has been done on day 6 here, but we try to prefer doing tracheostomy on the second week, probably after just passing the hyperinflammatory ARDS. You can change your ideas. People do it in the first week, but we usually do it in the second week, early part of the second week, just to pass it on the first hyperinflammatory phase of the ARDS. Do it percutaneously with a meticulous hemostasis. Stop heparin at least 6 to 8 hours before the tracheostomy, and wait for another 6 hours before starting the heparin. Weaning, probably I'm going to take in the next week with the thing. So just to have a consider that whenever we are thinking of weaning, it's an improving chest X-ray or it's an improving lung compliance with the same P-plat. The tidal volume is going to increase and improving gas exchange even in rest setting. So these three improvements tells us the patient needs weaning from the ECMO. And whenever we do veno-venous weaning, what we do, we don't reduce the RPM. We just keep the flow. We come down on FDO2 from every each 10% decrement to 21% and then come down on sweep, wait for the as a trial off period and then decannulate the patient. So this is very simple: oxygen challenge test, the CO2 challenge test, and then trial off and then decannulation. So our patient improved LV function on 10th day, 14th day, we were trial off more than 18 hours. ECMO decannulated on day 15. She's having severe cough. Slowly it is coming down. You can see the ABGs are very fine. The PO2 FR ratio has improved over a period of time. And she is getting mobilized. Weaning trial started. Day 23rd, we could take out the tracheostomy. And this is the plan for post-ECMO rehab and follow-up. So these are the joyful photographs of this patient. Now, this ends today's lecture on how we continuation of ECMO and how do you day-to-day basis, how we run our ECMO in that way. If any questions, I'm happy to answer.
Sir, we have some questions in our chat box.
Okay.
The first one is, sir, O2 ER and oxygen index is also considered for indication of PB ECMO.
Yes, we do it. Sometimes this oxygen index ROI.
Dr. Rahul, I think you can question sir directly.
Hello.
Yes, you are audible.
Yes. Sir, is oxygen extraction restriction oxygen index is also considered for indication BBECMO, or is the SESA or yellow criteria we only follow? What is the actual duration and what is the actual indication for initiating ECMO in this patient? And should we follow the O2 and oxygen index ratio as well for initiating veno-venous ECMO, especially in respiratory failure?
If you take my thing, we don't use this oxygen extraction ratio and all these things. As I've told you, we just calculate the Mare score if any patient comes to you. And because, there are a lot of practical inputs in our country where you have to convince the ECMO first and then you plan for the ECMO. If you just try to speak about ECMO when it is needed, probably it is not going to happen at that point of time. So you have to start talking. That's why I'm told you, whenever an ECMO for a ARDS patient you just calculate the Mare score. If it is touching 3, you start speaking to them. Probably when you are proning the patient and you don't know whether she is going to respond with the proning, you start speaking about ECMO. If she responded with the proning, don't put the patient on ECMO. But if not a prone responder, then you will get the time to get an ECMO. So this is my practical input, how we practice ECMO over there. And regarding the cardiac output, as I told you, we usually don't measure cardiac output in this kind of patient. None of the things are validated. Only I'm telling you this eco criteria like VTI, the velocity time integral, is a good measurement of your cardiac output overall in this kind of patient. So bedside echo probably gives you a good cardiac output findings in this kind of patient. Sometimes, like in this patient, as you have told, on day 4, there is some LV dysfunction appeared, which got naturally corrected over a period of time. Some viral ARDS, where we put after putting the patient on VV-ECMO, we see the heart started getting deteriorated, but they don't need always change to a veno-arterial support, because there is a transient deterioration and it goes up. So from where we get this, by doing regular echo and just measuring the LVOT VTI is sufficient for that. What are the other questions? I didn't find much.
Sir, actually, I want to know another thing. When I should consider an extra cannula, extra arterial cannula? When I consider an extra arterial cannula, especially in vena ECMO, or anything not be considered any other ventricular dysfunction and all?
Why are you not considering any arterial cannula?
When I should consider an arterial cannula in vena ECMO?
When?
Is
Yeah,
there
so
any?
yes, that is the thing. VV-ECMO, when you need to convert to a veno-arterial, this thing. Number one is the hemodynamic instability. This is very common. You have got a patient who is hypoxic. You put the patient on VV-ECMO, then you found your blood pressure is not holding because the LV dysfunction is the predominant one.
Yes,
And
sir.
you are not being able to hold the blood pressure. You are not able to maintain the perfusion with the moderate inotropes. Then you can consider putting an arterial cannula. Just change VV to
VA.
VAV.
Or okay.
So add arterial cannula over there. So this is the where. In VA patients also, we do what we do, putting another venous cannula in the neck, where we get a hypoxia, upper body hypoxia. As I told in the previous one, this is our Harlequin syndrome. So VV to VAV is because of the not able to maintain the hemodynamics after putting the VV ECMO, or to not maintain the blood pressure, not maintain the cardiac output. That indicates VV to VAV. Or for VA to VAV is an indication for your hypoxia is predominantly causing problem, or you have a Harlequin syndrome, upper body is hypoxia.
Thank you, sir.
Any other question?
Sir, during the lung rest, should you also consider the driving pressure for resting lung, or only just control the air pressure less than 30 cent water pressure, as you told? Is any other pressure should be made?
Driving pressure is again to be considered over there, but see, there is a marked change of this kind of practices after COVID, because COVID has taught us that sometimes driving pressure can be very high, but we have to accept that. So that's I'm telling you, every patient is different. Since COVID has happened, we have not been able to get a good marker of how to ventilate this kind of patients on the ground. Because initially people used to give a very zero kind of ventilator after putting the patient on ECMO. But we have seen what happened. The lung got completely collapsed and very difficult to open them up. So that's why some kind of ventilation, as I've told you, the your pressure control, your plateau pressure should not cross 25 or 30, should be your target. So this we follow, because as we have seen, if we allowed that to happen in the first part of the ARDS or the second part of the ARDS, when lungs started getting a little bit opening up, that tend to rupture. And if once it's ruptured, it's very difficult to come out of ECMO.
Okay, thanks.
Any other question or query or comment? So if no questions are there, so thank you very much, sir, for this excellent class and a very explanatory understanding of the ECMO and how to manage the ECMO in practical session in our day-to-day life. On behalf of Heartlines IACTA West Bengal, we sincerely thank everyone for for this joining us this evening, and we also invite our all the interested colleagues. Please join our society as a member to be a part of our vibrant academic community, which are dedicated to continuous learning, collaboration, and advancement in cardiac anesthesia and the critical care.